forward without paralysing the patient. And you can see on the other one, it's over about 2-3 levels of the spine as well. It's not just in one level. So did this almost all from the back, but also through the chest. Chest reaching around just to try and free up between the aorta, which is in a different plane, and feel where the butt, the vertebral body. We've come in the back and taken this nerve root, freed all that, and we've basically run an osteotome through the spine, sharp, it's like a chisel effectively, through the spine, to sit between the aorta. The aorta sort of falls away out front here, sits between the aorta and the tumour. We end up with an X-ray that looks like this. This is the specimen X-ray. You see the 3 ribs. We see half the spine. The tumour here. This big grey mass here. And then looking straight down on the spine, this is the spinal canal here. This is where we've run the osteotome. The aorta was sitting here. This is the tumour that was sitting in the chest. And at the back, all come away as one piece. And the spine has some screws put in it. And that came out as an en bloc. So we managed to get all that out in one piece. This is one of the Canadian specials. Osteosarcoma, so this be a young man, tumour abutting and invading the lining of the aorta. So, true Canadian style, the only way to deal with that is to cut out the aorta. There's the spinal nerve roots at the back there, the whole of the spine's gone. There's the aorta sitting on front of it, it's all in one piece, with the tumour, and there's the reconstruction. And that's why it's great working here, because actually I can go to any vascular surgeon here, and I can say, I need to replace a bit of the aorta, what can you do? They go, well, that's easy, I do that every day. I'll do, we do aneurysms, we do it's, that's no big deal. I think it's an enormous deal. They think it's no big deal. I say I'm going to chop off half the spine. They say that's ridiculous. Why would they couldn't even conceive of doing that. But to me, that's relatively straightforward. And because there are so many people who are expert at what they do, you pull them together, and actually, for any one individual doing their bit, it's a normal day at the office. But if you try to do it by yourself, it would go wrong. It would be a no-brainer. It would go wrong. So we have excellent sort of colleagues, excellent sort of facilities, spinal and plastic surgeons come and play their role, and we often do a lot of these operations with 2 spinal surgeons together because it's 8, 12 hours, sometimes 2 days. We put the patient to sleep in ITU overnight and go back and do the second half the next day. So these are big days at the office. Any questions?
Well, thanks very much. I want to have a chance to keep my colleague under control. In our feedback, there is a sort of group of people who say we want to see more of the sort of blood and gore end of things, and that I was wondering whether any of you are getting horrified by this presentation. But I think it's been interesting, those of you who've come to these before, that we started off looking at the sort of research application. This is very much at the practical end, and these are really techniques that have been developed, I would say, more by trial and error than by systematic research. Although we've gradually learned, we've gradually started to get trials now supporting this sort of approach, which have previously just have been, these sort of operations have been done, and we've gradually learned from our own experience and from people around the world. So I've got 2 things before we start doing the question. One is, please complete the feedback, because I want to know whether you want more of this sort of stuff, or is this the last time you're ever going to come here? And the other thing is just to promote you that actually the next joint ventures lecture is about physiotherapy research, so they don't do blood and gore on the 23rd of November. So that's our promotion. So has anybody got any questions to Jeremy about this?
I just wondered, do you think you're winning in terms of educating other health professionals? I lecture health professionals, and I think one of the things that's a real issue in practice, you are informed of the signs and symptoms to look out for, but very often, you may be presented with someone who's masking their symptoms or relatives that have kind of subtle symptoms, because the motivation to continue with treatment and the fear of being taken off treatment because they've got disease progression, they might not report symptoms. And you know, I think one of the challenges about educating people is, yes, you can say to people, look for these signs and symptoms, but it's the challenge of teaching people how to have quite sophisticated conversations with people to educate them about, you know, if you get these symptoms, we can do this with it, and yes, you would stop your treatment for this period of time, but it doesn't mean say the treatment stops forever, and there are different treatment options at the end of it. So it's not quite as straightforward as we just need to be aware of picking up all these signs and symptoms, is it?
I mean, I think that our problem at the moment is that we're so far behind the game in terms of getting these patients identified, getting them into the system, that any form of education is good education. Because if we're talking about oncologists who still don't understand the role of surgery, and they're our prime team that we're interacting with, then you know we're a long way off. So, and I mean, we lecture to the oncologists, and they are enormously interested in, oh, I didn't know we did that. Oh, I didn't know you could do that. That's if we're at that level, at the last tier, then the feedback up the route is miles off the subtleties. We're really, you just got to bang it. Look, this exists. It's treatable. Please be aware of it. And then the subtlety. When we've talked about every time that I have a meeting with TSSG, there's a question about the unknown primary. My answer to that is that's a whole different ball game. We don't even sort out the patients. 75% who know they've got a cancer. We're not even sorting them out yet. So let's tag the 25% on after we've sorted out the 75%. Because at the moment we regularly get calls to say, I've got this person who's been sat in hospital, getting weaker this week. I've got an MRI yesterday when he became fully paralysed in hospital, and you know, my registrar's given me a call today, and they've had a call with the radiologist. It's 5 o'clock now in the evening, on Friday evening, and the patient's been in hospital progressing in front of somebody's eyes, and they only get an MRI scan on Thursday, which they only get reported Friday afternoon. That's how brutal it is in terms of these the subtleties. We'd love to be in a position to have this fine-tuned, but we're not. We're just trying to tune into Radio 1 at the moment.
Yeah, I mean, I think that the kind of initiative for the oncological emergencies education
is going to make a big difference, and that's what we're planning into that. So we're going to have lectures within the acute oncology service. It can happen every 4 months. We're trying to plug into the GP training. So, but this is, well, we only set up the TSSG, effectively only have a formal TSSG last week. So it's early days, but patient leaflets are ready, pathways are ready. If we jump the gun with introducing it, we're not going to be ready. So there's a lot to set up for it. It's a big problem.
Right, another question.
May I just say thank you to all of you involved. I've survived breast cancer and my sarcoma, and I'm eternally grateful. So thank you very much.
Well, I think it's very brave of you to come to all this. Anyhow, there's one more question, and then we'll stop.
Can I just say to you asked whether we want any more of this. Now, there are obviously some very learned people here, but I represent a patient participation group in the north of the county. And they know, as a partition group, that I come here, and they say to me, what do you know about bats? What do you know about this? What do you know about that? Have you had a lecture about this? You see? And the thing that I always say to them is, if I've had a lecture, the bloke who stood there, or the lady who stood there, knew what he was talking about, and if you go and ask them the relevant questions, you will get the relevant answers straight pat. You don't have to go and beat about the bush with them anymore. So what it does for me to attend these lectures is some of the things go over the top of my head, but I realise that the people who stand here and who are a part of this know what they're talking about, know what they're doing, and they can actually put that to a patient who comes to them in a way that they can understand. So for me, it's good to come here because I can say, yeah, I saw a person about backs and they knew what they were at. If you want to ask them, do it. And that's the benefit.
Well, it's very good to hear that. Thank you very much. Fiona will take that down. Thank you. Right, well, thank you very much indeed. Duncan and Jeremy.